Welcome to our fifth session for our chronic disease structured collaborative, our CKD education and support resources for patients and care partners. This will be presented today by Karen Crampton. She is a social worker from Michigan. We welcome her and we'll have her introduce herself in just a moment. But before we get to that, and we will leave Karen for last, let's just go around and introduce ourselves. I'll start it off, and then if you are a participant and if you participated in last week's action plan, please share a little bit about your results. If you choose not to want to share with that or hadn't participated in that action plan for last week, feel free to just pass on that. So we'll move along. I am Mary Funseth. I am a social worker, and I am from one of the parent organizations, Metastar, part of Superior Health Quality Alliance, and I work with the patient family engagement, chronic disease, and also care coordination, and I am going to be your facilitator today. I will pass it on to Diane.
Good afternoon, everyone. My name is Diane Carlson. I'm Executive Director of Midwest Kidney Network, and we are very passionate about anything that can be done with early identification and treatment of people who have kidney disease. So Karen, thank you for being our expert and very, very experienced speaker today.
Thank you. So next we'll go to Deb.
Good afternoon. I'm Deb Winia, Sanford Laverne, down in the very southwest corner of Minnesota. I do employee health and looking at also prevention for our employees. And then I also experienced my father went through all of this in the last year and passed away in October.
Thanks, Deb. Thanks, sharing for your personal story as well. Dr. Campbell.
Good afternoon, everyone. I'm Orville Campbell. I serve as the Vice President for Strategy and New Business Development for MPRO. My background includes training as a nephrologist at Emory University. I've private practice for over 25 years before transitioning into an administrative role. Over the years, I've served as a medical director for multiple clinics, for ESRD clinics for DaVita, as well as RAI between the years of 1997 and 2019. Also have a lot of experience in the correctional healthcare space, as well as UM and UR. And I'm looking forward to your talk, Ms. Crampton, on this very important topic. And CKD is my passion. Even private practice, that portion of it. Dialysis was great, but prevention, progression of CKD and finding CKD will always be my passion.
Thank you, Dr. Campbell. Janelle.
Yes, hi, my name is Janelle Gagne. I'm a clinical dietitian. I've worked in the area of nephrology for 33 years now. I'm also a member of the Medical Review Committee with the Midwest Kidney Network, and I too share everyone's passion for early detection and prevention.
All right, thanks, Janelle. Candy.
Yeah, hi, my name is Candy Coles, and I'm the Quality Improvement Director for the Midwest Kidney Network. And I am just very glad to be able to attend today to hear what you have to say about CKD and get some really good opportunities to learn and see what we can take back to the network to help shape our projects.
Thanks, Candy.
Mm-hmm.
And then Diane, you're listed twice. Is that because you are here twice, or there's someone else utilizing your link?
I think it might be a mistake.
No,
Okay.
I think Renee is on there.
Okay, Renee?
Yeah, I think so. She's because I linked in as Diane too and had to change my name.
Okay.
Oh,
Yeah.
so yes, Renee.
Yeah, I just clicked onto the link. I didn't realize I was
That's quite all right. Renee,
Sorry
please
about
introduce
that.
yourself.
Yes. Okay, I'm Renee Nelson. I'm the Patient Services Director at the Midwest Kidney Network. I've been there for about 15 years. And prior to that, I worked as a dialysis social worker for over 8. And I'm very happy to be here. Thank you.
That's wonderful. Thank you. So then, Karen, will you please introduce yourself?
So, as you've heard, I'm Karen Crampton. I work for Michigan Medicine, also known as University of Michigan. We kind of switch it up every now and again. I'm a social worker in the home dialysis program, and I'm also a social worker in our multidisciplinary CKD clinic. So that's the experience that I use to draw some of the resources that I have for you today, because those are patients who are anywhere from stage 2 down with kidney disease. So I'm hoping to just sort of share some of that experience with you and some of those resources. So that's me.
We appreciate having you here today, Karen. We look forward to your presentation. So today's presentation objectives are: identify education resources for CKD patients, identify support for care partners, and learn how to improve education efficacy. So we are going to now hand it off to Karen, and she will lead us into this by talking about our objectives some more.
Thank you. So before I start about the objectives, I just want to say we are in the middle of clinic. There might be a little traffic in my office, but also the slides, when I put them together, there's a lot of content. I don't have a lot of jokes to make you laugh and really intrigued, but I wanted you to have some really solid resources to go to. So I see that there's a printout that's available for people who are interested. And I think that that's where I put my energy was with the content. So let's get to the objectives. Why are our objectives important? So I was talking to Rachel Bender, who many of you know, and we were talking about the incredible impact that this diagnosis has. It impacts people from a financial standpoint, many of whom are already disadvantaged financially. So this diagnosis really hits people hard. It can cause depression and anxiety because they don't know what to expect. They don't know about their life expectancy. There's huge changes that happen in their life. And sometimes as a result, we see denial. And denial is a healthy way for our brains to protect us from things that are too difficult to handle at a given moment. But it can become a problem, as you know, when it gets in the way of acceptance and sort of moving forward and following a treatment plan and that sort of thing. So we really need to help patients work through their denial with this tremendous diagnosis. Grief and loss is another huge part of the impact and a consideration when we think about our objectives. I read an article many years ago, and a patient, they described their kidney disease and being on dialysis as a loss of dreams. That was their biggest loss, was the loss of dreams, the dreams they had about their future, about their retirement, about being a grandparent, about being a parent, whatever that loss might be, it's wide and it's deep. So thinking about the impact of this diagnosis is really important as we support patients to try to understand our educational efforts. And pill burden, I think our patients have the number one, at least in the top 3 level of pill burden, many of them taking as many as 18 plus medications. So in other words, these folks need a lot of support, and we can throw a lot of education at them and a lot of resources at them, but what I want to talk today is about how to make that as effective as possible. Next slide. So here's our polling question. We don't have a formal polling mechanism set up, so it's a small group. So I'll ask you, at what stage should CKD patients receive dialysis modality education? So if you had to guess, would that be stage 3, 4, or 5? You can put something in the chat if you like. I'll just give you a couple of seconds here to think about that. Drum roll. The answer is stage 3. So that seems really early, and I've heard providers and professionals say, patients aren't going to take that well, and they may not take it well. But I think one of the most important messages I have today is that this is an iterative process. We can't think we're going to educate patients once about dialysis modalities and that they'll be able to hear it. I give the example of when I worked on the hemodialysis side of our clinic, I had a patient there that about every 6 months I would say to him, "Oh, I want to see you go over to home dialysis. You're a perfect candidate." And then about 8 years went by and his hemo access failed to the extent that he had to do PD. And by that point, I was over on the home dialysis side. So I said, "Finally, you're here." And I said, "What took you so long?" He said, "You never talked to me about home dialysis." So my point is, it's iterative. We have to consistently talk to patients. And at stage 3, I think next slide will tell us why it's so important. So back to the repetition piece, it improves learning and retention. And I think when I get a referral to do education with a patient at stage 3, one of the first things I say to them is, this is a scary thing to hear, and you are not there yet. And when you do get there, or if you get there, you are going to be well educated. You will have learned the information while you feel better. I can't tell you how many times I've walked into a room or taught a class and a patient was like this, because they're tired. They might be uremic. They cannot incorporate the information. I've had some patients in stage 3 attend our dialysis or modality class twice because they really want to absorb the information. So we also know about cognitive impairment potentially for patients with long-term CKD. So we want to reach them as soon as possible and repetitively. Back to that piece about denial, adjustment and acceptance, it can take a while. So we want to make sure that we are giving patients opportunities to hear it when they're ready. And because we don't always know when that is, doing it regularly and repetitively is their best chance to absorb the information and make a well-informed decision. And for some people, I hear over and over how limited the education about CKD or dialysis might be. And, that can also be an access issue. So we want to make sure that people have access to education. And the earlier we start, the more opportunities we'll have, even though it may be limited. So waiting till the very end is when we get crisis situations. Can anybody think of any other reason why we should start dialysis education or CKD education early? Stage 3? Any reasons why you think we shouldn't? I think the number one reason I hear why we shouldn't is that it overwhelms patients. And, I go back to the point of we need to have a lot of opportunities to catch them at an opportunity that they can hear it. So, all right, next slide. So we know why it's important. We know when it's important. So I just wanted to take a quick minute to talk about how do we improve the efficacy and make sure that we're providing education in a way that is going to be optimally received. And one of the ways is to inquire about health literacy. And, there's a tool called the Realm. It has some pluses and minuses, but it can give you a very quick look at what is a patient's level of health literacy. So some people use that. Some people say, if I provide information to you in writing, how difficult will it be? Will it be difficult for you to read it and understand it? Or on a scale of 1 to 10, 10 being I can read this easily, 1 being I'm going to have someone read it for me. Where are you? Where do you think you fall in that scale of 1 to 10? So just kinds of questions like that to make sure we understand, regardless of their education level, right? This should be universal precaution. I have a patient who I spoke to yesterday who has a college degree. And as I teased out some of the barriers to getting things done, she said, I've often wondered if I'm dyslexic because I have a really hard time reading things. So you get my point, that really needs to be vetted. Using the teach back method, we use that here a lot. Really needing to understand what the patient heard us say, because otherwise sometimes we can fire, it's like shooting a fire hose and asking people to take a sip from it. It's almost impossible. So we want to make sure that we're kind of teaching in chunks and that we're saying to the patient, I want to make sure that I explain that right. Can I hear you? Tell me what you heard me say. And oftentimes it is not what we thought, what we intended. So then you say, oh, my mistake. And some of you might be experts. So sorry, I apologize if you're an expert at teachback. But the reality is we can kind of better assess what the patient is hearing us say so that they can move forward with whatever it is that the physician is recommending. Utilizing motivational interviewing. Again, I apologize if I have any experts here on the Zoom, but getting a good understanding about where people are in terms of their level of commitment and motivation to making change, because sometimes we need to help them along in terms of getting on board with their medications or with their exercise. I have an example for that if we have time. I'll talk about that for a second. But, you know, on a scale of 1 to 10, how likely are you to make this change? And getting an understanding of, well, why aren't you at this end or why are you at this end, so that we can have a better understanding of the patient's narrative and the nuances that go with that. Assessing for additional needs. We don't want to neglect the fact that what you see at a visit is really the tip of the iceberg. So we can make big assumptions about what the tip of that iceberg represents, when in reality, and I rely heavily on social work. I know this is a huge plug for social work, but I can't tell you enough how important it is that patients feel understood and that we respect them enough to address the underlying elements of their lives, their bigger narrative, to understand what impacts their ability to commit to a treatment plan. And a lot of that is socioeconomic. It could be cultural dynamics that we're not aware of, gender identity, thoughts, concerns that patients might have that we really need to be sensitive to. So often I'll have a patient come in and the physician will tell me the patient doesn't have a blood pressure monitor. They can't afford their medication and they just lost their job. So it's really hard to expect them to go fill their blood pressure medication when they can't afford the copay or whatever it might be. So again, we really need to make sure that we're supporting beyond the tip of the iceberg. And I guess the bottom bullet is inclusive of that. Okay, next slide, please. A little bit more about education efficacy is taking advantage of technology. And I see more and more patients who are technologically oriented and they want to know, is there an app for that? And sometimes there is. And there's things like the Mango Health app. Have you guys, I'm not sure if you guys have used that. It's so strange to be on Zoom and I can't see everybody to get a nod of heads. But the Mango app is a health app to help people manage their medications and other elements of their chronic conditions. So I think the Baxter's CKD and Me app, again, some pluses and minuses, but I think that it is a very useful tool to help patients try to navigate their care and do some of their own education. And it's sort of set up in modules, so you can watch it over and over. And I think that's been a key element for patient success. So the Baxter CKD and Me is a good plug for our patients in early stages and in later stages. It's helpful to know a patient's learning style. If I have an auditory learner and I give them a stack of hard copies, they're the patients that usually leave it at their chair side when they leave, because they need to hear it. They want to see it. They want to handle the PD supplies or whatever it might be. So really kind of asking patients how they learn best. Including, there might be limitations like needing large print materials, and that's not always easy. Sometimes you can cut and paste materials into a Word document and make it larger. So sometimes those are limitations, or I've been in a clinic and I pull up the materials and I'll enlarge the font so that they can see it that way. And also engaging the support person or family member that they might bring to appointments. If they don't bring someone, you might encourage them, because there's a small percentage that patients are able to incorporate at any visit. I've heard as low as 30%. So If you bring someone else, that's going to up it to 60 and maybe more, hopefully. Okay, next slide, please. Okay, so this is where the slides get bulky, and thank you to Jerry and Mary for helping me break it down a little bit. So I just want to go over some of the resources that we have for patients and their care partners. So let's start with Kidney School. So Kidney School is an online program that is set up in modules. You can type in whatever your concern is, and then the module will come up, or you can follow it step by step from early CKD to dialysis. So that's a really good, and I'm not going to go into depth over each of these, but Kidney School is a really helpful resource for people who have a computer and access to internet. You can also type in a module yourself. If a patient says, I'm struggling emotionally, you can go to kidneyschool.org and type in coping and print out that module for the patient. The other thing I like about that program is that there is also an auditory, you can listen, it's almost like a podcast. You can listen to the modules for people who might have limited literacy. So I encourage, I think that that's a tremendous resource. These others are phenomenal resources too, and offer different support services to patients and different educational efforts. Medicare.gov is a resource for people who might have questions related to disability, and I have another slide coming up. But so these are some other good resources too. Okay, next slide. Some more resources for early stages, and some of these are also good for later stages, and so there will be some duplication. But one of the programs I love is the National Kidney Foundation's Personal Action Toward Health. And the thing I love about that is it really teaches people to get in the driver's seat of their healthcare. It teaches them about the importance of their diabetes management, about understanding your medications, about how to take them. So it's a 6-week, used to be in-person program here in Michigan, and now you can do it via Zoom, which, if you have to think of anything positive that came out of a pandemic, it's that I think that patients have access to different resources that they didn't have before, potentially. So the Personal Action Toward Health, if you can get a patient to engage in that, they will soon be your peer mentors because they come out really feeling in control. I already mentioned the Baxter app. Some other resources for patients when I talked about kind of what's going on under the tip of the iceberg. So U of M has an incredible comprehensive gender services program. And I think we have a lot of people feel like they need more education related to that topic. They have online learning for patients and for providers and professionals. So if you're looking for more information, that would really be an exceptional resource. And I'm not just saying that because I'm a Go Blue fan. It really is an exceptional resource. Other needs that people have, we see food insecurity, and I know the dietitians are used to seeing that. One of the resources I use frequently is foodpantries.org. When you go to that website, it pulls up the page that lets you search by state. And then when you go to state, it lets you search by city, and it will pull up all of the resource, like all of the community resources, churches, Salvation Army, any organization that offers, sorry, I need to delay my reboot, that offers food for folks. And I remind people that nobody ever thinks they're going to have to go to a food pantry. And I tell the story about one of my patients who said his wife actually worked at the university and he couldn't work and they struggled financially. And he said, I finally took your advice and I thought I was just going to get canned goods. And I went and I was able to get meat and produce. And he said, tell your patients not to worry about being too proud, that they're there to help you. And even though you don't expect to ever be there, that's what they're there for. So I do share that with folks because food pantries have come a long way from when I was a very young social worker. So I encourage you to use that site. Mayo Clinic is well known for so much education related to everything from kidney disease, diabetes, cancer, transplant, all kinds of things that our patients experience. So they're a tremendous resource. And we have an education clearinghouse that you type in what your concerns are, and up come lots of resources. And as does the Wisconsin Chronic Disease Program through their human services. That was a really nice, because I was trying to find some things for not just Michigan related, and I was pleased to see what they offer. It looked much better, I have to say, than the current Michigan Human Services website. So I was glad to see a chronic disease plan for patients, a plan to help patients. So those are some more resources. Okay, next slide. Later stages, I mentioned, you're going to see some of the same options. Kidney School, incredible resource. There are peer mentoring programs that are the National Kidney Foundation, Midwest Kidney, Dialysis Patient Citizens. There are through a variety of agencies, and I can't think of a more effective teaching program than using a peer mentor. We use a peer mentor in our dialysis education classes and have a significant increase in home therapies uptake because of our peer mentor. And we use a survey at the end of class to find out what was most valuable, and it's the peer mentor. So even patients with CKD long before dialysis, knowing how someone is living with their CKD diagnosis, living well with it, managing their diet, their mental health, their medications, their care in general. So finding that someone is able to do that and still feel hope and positive coping mechanisms is a really beneficial thing. So a peer mentor is tremendous to have as a resource for patients as it relates to education. And then the choosingdialysis.org at the very bottom, that is an online modality program for later stages of CKD. It was put together by patients and by professionals. So it has a nice balance between looking at what is important to the patient, what are their values, so that it has sort of these slider bars that you use so that you can, at the end, have the website sort of weighs in on what you identified as important and what would be the best modality for you. So choosingdialysis.org is a good one for that. Next slide is more, I believe. So the other thing is that you know that patients can be referred for kidney transplant with a GFR of 20, and they're going to want, and if they don't ask, we should be referring them to the UNOS network for education related to transplant. And also National Kidney Foundation does a great job with education around kidney transplant as well. And we don't have to wait till their GFR is 20. We can include that in their stage 3 education, because if we help them get referred at 20, they will start accruing time for their transplant wait time instead of waiting till they get to dialysis. And I didn't look up the wait time in your respective states, but in Michigan, it's 5 to 7 years. So the earlier we can refer, the better. If we wait till their GFR is 20, can you imagine the shock of being told now you can have a transplant? So we want to avoid that. We want them to start accepting it and thinking about it, and potentially looking for a donor when they're in stage 3, so that when they get to that point, they are not in denial, not in shock. They're more in the acceptance phase and ready to move forward. Because it's difficult, as some of you may know, it's incredibly difficult to go through the transplant evaluation process, all of the testing, and additionally, the list is not only long, it's hard to understand. Sometimes we use jargon, we use medical jargon that is really difficult for patients to understand. So we need to be aware of that. And again, the sooner we start, the more time they have to ask questions at their appointments. My Life, My Dialysis Choice is another great option to share with patients for ways to learn about which treatment modality would be best for them. And then another resource is the Job Accommodation Network, and they are intended to help people with disabilities find employment, rehabilitation efforts, maintain employment. It is a really good resource for patients who are concerned about their job or finding work. Okay, next slide. All right, so now we're going to look at some broader resources. So this slide is on advocacy, and it's a good opportunity here for patients and professionals to become involved in making a difference in public policies, in fundraising, in creating education for patients, and advocacy, like things like the State Rehab Services Bureau for the Blind. They have incredible resources for our patients to state survey agencies handling grievances and complaints like our Midwest network. You know, patients need to know that they have someone they can go to when they feel that they need someone to advocate for them, to have their back, that they can say what they need to say without fear of any retaliation in their clinic or by their provider. So patients need to know that they have some support, and these are all excellent resources for that. How am I doing on time? Sorry, I lost track.
Doing well.
Okay. Okay, so these are more advocacy opportunities. The American Kidney Fund. Many patients have concerns when they start dialysis. How are they going to afford insurance? And the American Kidney Fund is a program that helps with insurance premiums. And they have an application people can download themselves. They have to be on dialysis. And it even continues to cover them for their first year of transplant. So that is a huge resource. I wish somehow they could help prior to needing dialysis, but that's the limitation currently, and lots of rules related to that. So they're a great resource to provide patients a little bit of reassurance that there's help down the road once they start dialysis related to that specific financial concern. The Americans with Disabilities Act, you know, I've had, not so much now, I do see it once in a while, but I will see periodically a patient who says my job won't let me leave for my appointments, or something like that. And yes, they can apply for Family Leave Act, and they can also ask their social worker, another plug, to have a social worker on board, or hopefully all of you have access to a social worker, because we can put together really lovely letters that say, please accommodate this patient based on the Americans with Disabilities Act, and help them understand that they need to follow those rules. So another advocacy element for our patients that is backed by and supported by ADA, as well as the rest of these agencies as well. Next slide. So I'm not going to go through this, but I thought it was important to have in the handout that again, patients will come in and say, I don't have insurance, or I just lost my insurance, or I can't afford insurance. And, you know, there are ways through the marketplace, also known as Obamacare, to be able to get affordable coverage. Some of those plans dictate where a patient can get dialysis, so sometimes that's an issue. But nonetheless, it's important for patients to know that as long as they've paid into Social Security, they will be eligible for Medicare once they start dialysis. So, and it immediately if they do a home program, and 90 days if they do in center. But again, I just wanted to have that kind of set up for you so you could refer back to it if needed. Also about insurance, helping people with COBRA, because that's better for them to have long-term, and if not, helping them find alternatives. There could be hospital charity care or indigent waivers. Dialysis programs have indigent waivers for people who are, for example, a little bit lower in the emergency, Medicaid only. For maybe undocumented immigrants, they might need to get dialysis through an indigent waiver. Many years ago, I used our network to advocate for uninsured patients to be able to get dialysis, and they were really exceptional at helping clinics understand we all have to bear the brunt of that. Not one clinic should be doing that. So helping patients know that, again, they have another advocate in the network if clinics are refusing them. So I haven't had to do that recently, but I will say just providing some reassurance to patients that they have options for insurance or care. Okay, next slide. So as I said, there's been some benefits to access to care as a result of the pandemic, and that is more video visits, more phone visits. I understand not everybody has a computer and internet access. More and more people are getting computers or have smartphones. And this program here does provide internet support for people who may not be able to get internet or the type of speed that they need to have video visits. Which, by the way, this also expands the opportunities for people who need mental health care. So, you know, if they can do video visits, maybe before they didn't have a car, they didn't have gas, they had no one to take them. Medicaid transportation is an absolute nightmare. They will for sure miss their appointment. But this it does provide the best opportunity for people to get a variety of care that they need. Okay, next slide, please. And then how to enroll, it's pretty easy. I walked a patient through it. So you might need someone to help walk them through it, or they can get a hard copy application if that's something that's preferable for them. Okay, next slide. So I told you my slides were not funny, but this slide and the next slide, when patients come in and say, oh, my GFR is 20 and I just don't feel well enough to work, it's really hard to get disability before they start dialysis. But this is the requirement for disability under Social Security for a patient who has later stage CKD, but not on dialysis. So, you know, we might see the creatinine of 4, but then it's also, next slide, please, it's in addition to one of the following. So we might see one of these others. It's real, I haven't seen it all that often in order to help patients get disability prior to them needing dialysis. But if you do have a patient that meets these criteria or this criteria, you could help. The best thing you could do is print off the lab that has their creatinine, print off a note about their renal osteodystrophy or whatever it might be, so that they have that when they take it to apply for disability, and that will increase their odds that they'll get approved the first time. Okay, next slide. I think that was all about that one. So the next bit is about medication resources, and some of these may look really familiar to you, and social workers on the call, you may already be using these. So the one that stands out to me is the GoodRx, and most of you have probably heard about that. And GoodRx, the example that I use with that is if you use the GoodRx or some similar discount coupon program, but we just tend to use GoodRx more often. If you use their card without your insurance, for example, for sevelamer, we have patients who try to fill sevelamer with their insurance card. Let me back up. Sevelamer being a phosphate binder, and you see that needed later in the CKD stages. But if they need a phosphate binder like sevelamer, one of those ones that cost almost $1,000, the insurance might cover a few $100s, and the patient is responsible for up to $600. So if they use the card, they can get it for anywhere to $50 to $60 without using their insurance. So these are all resources that you can look into, and over-the-counter meds as well as prescribed, lots of options for patients. Okay, next slide, please. So let's just talk really quickly about care partners. I'm not going to read this slide, but I wanted you to have it. You know, the slide here is a quote, so it says caregivers, but I had a patient's wife, actually, I was at a conference, and she stood up and said, can we use the phrase care partners, because caregivers implies an imbalance of power, and my husband and I are partners in this. So since then, I've always used the word care partners, and some people say, oh, semantics, but I think every opportunity we have to create a closer relationship with patients who need a lot of support, I think every chance we get, we should take it. So huge impact on family members, care partners. So I frequently look to the care partner and say, how are you? How are you doing today? So remembering that we need to ask how they're doing. They're helping patient manage their mental health, their medications, their transportation, their really down days. So making sure that that they are getting some support at visits and acknowledging when they're doing a great job, say to them, you're doing an incredible job here, and it's abundantly clear because patient is doing so well with your help. So acknowledging that goes a long way. Okay, next slide, please. Here are some additional resources for care partners. So the AARP care guides are fantastic. Also, one of the things I didn't list here is the Alzheimer's Association. Even though you might have a CKD patient that doesn't have Alzheimer's, for families who are looking for support, they have some really good options there. So sometimes I refer people to their website as well. So these are all great options in order to help care partners. Okay. So this is a super busy slide. I don't expect you to read it. The reason I included this is because oftentimes we get patients who have poor self-management skills, self-medical management skills. And this was out of Chapel Hill. And the thing that I liked about it is there's a whole bunch of questions that you can use to ask a patient, especially a peds to adult patient, a transitioning patient, but also young adult, maybe even an adult patient. So things like, how often do you ask your doctor questions about your medicines? How often do you work with a doctor to take care of a new health problem? On the left, under managing medications, I'd probably leave that more open-ended to say, what do you do if you need to fill a prescription? So I just thought these were some really good questions to inspire patients to take charge of their health if they won't do the Personal Action Toward Health series, the program through National Kidney Foundation. But I think this, again, is busy, but I think it is an opportunity to take a look at how are we encouraging people to really get in the driver's seat of their healthcare, because we can provide all the education we want, but they really need to take it and do something with it. I think that's my last slide. Is it? Yes. All right. Questions, comments, thoughts? Certainly happy to talk.
Thank you so much, Karen. This has been really helpful. And I wanted to mention to our audience that a few of our slides, of course, has some real specific resources on them. And Jerry and I are going to be working together to put forth some sort of handout so that you will be able to access those easily, as well as this last slide. I really love the idea about these support services on this last. So we would also possibly create that into something for you all, as well as for, a handy guide. So now we'd like you to open up your mic if possible, and ask your questions of Karen. Here we have her right in front of us. Let's ask questions. And if you don't feel comfortable speaking your question, please feel free to put in the chat, and Jerry, who's with us, will go ahead and let us know what's in the chat.
Karen, thank you so much for a wonderful talk in regard to resources. Excellent talk.
Oh, thank you.
Glad you told us when to refer patients for education. But the industry shoots itself in the foot and says refer to a nephrologist when the GFR is less than 30. So individuals kind of get it in their minds that, if you need education, then it needs to be GFR less than 30. You don't have to worry about that for education. So thanks for really pushing early education. One of the things I also wanted to highlight, that less than 60 is so important because that's when the wheels begin to fall off the cart with secondary hyperparathyroidism and so on and so forth. So dietary education is also important at that point too. But thank you so much for a wonderful talk.
My pleasure.
Maria put a really great comment in chat, and I was just wondering, Maria, if you even wanted to talk a little bit more to it because I'm not sure I can do it justice when I'm reading it, because you're talking about, culturally the challenge we face. Historically, we can educate all we want, but with our culture, that makes it difficult. Often requires things to be broken before we can put them back together again, instead of doing that early education, I think is what you're speaking to, Maria, and how we as clinical providers always want to care or provide the care to the patients. I don't know, Maria, are you comfortable talking a little bit more to that? Because I'm not sure if I did it justice. Oh, you're at home and you don't have your mic. Can you just let me know in chat if I kind of if I said it correctly? Or
Did you want me to speak quickly to her question since she doesn't have a mic?
Sure.
Okay, I agree 100%. And I think that oftentimes prevention gets lost in the cost. And I think it takes a lot of work to demonstrate that having staff to address these things, because a lot of times the visits are so brief, it's really hard to address. I talked about the tip of the iceberg. We're lucky if we have time to touch the tip of the iceberg in many situations. So much less the creating a narrative and all these beautiful things that are ideal in a lot of medical centers. I think it's convincing people to take a preventative approach. And some places are willing to consider a pilot and really do a research study to show, and there is a lot of research out there to demonstrate the impact of avoiding crash landings and people starting dialysis without any care, prior nephrology care. So I guess I agree with you. I think that we have a bit of a cost culture, and I understand finance, so I don't want to seem naive related to that. But I would encourage looking into potentially a pilot at creating a multidisciplinary effort to manage patients with high utility chronic illnesses like CKD.
that is a great point, Karen. And actually even something, Mary, you and I can talk about that, just even across the board for our patients with multiple chronic conditions, and how we can help maybe through another structured collaborative if people are interested. Diane had a question about, can you explain more about and I'm sorry, I missed this part, so if I'm saying it's wrong, but the REALM-SF or REALM-SF that you spoke about?
It's one page, and I know you can't see it, so this is probably ridiculous that I'm even doing this, but nonetheless, it is a question of 1, 2, 3, 4, 5, 6, 7. You read aloud the question and you ask them if they understand it or what they. You can also do it in a laminated. Some people laminate it and ask the patient to fill it out themselves. So you ask the patient to read as many of those words as possible, and then it's got the scoring at the bottom. And our transplant program uses this to try to get a baseline or to get a better understanding of where they might be. And, it grades you based on 3rd grade and below, 4th through 6th, and up to high school level of health literacy. So there's been some criticisms of it, but I have found it completely useful. So, is it 100% accurate? I'm not quite sure. And there's been a lot of research related to it, but so that's what that tool is asking people to read a variety of medical terms that we use in healthcare.
I have to say, as a fellow social worker, I love that too, because we all need to remember that literacy isn't just about reading, which you all I'm sure know. It's sometimes just literacy about a particular topic. If we were talking about cancer literacy or literacy about cancer, I would definitely be in need of a lot of support because I've never really worked within that area much. So if I had to come in for something related to my kidneys, also a little bit better now since I've gone through the series, but definitely literacy is so important, just to get directly with the patient so they can learn, as you already mentioned, at their level and where their needs need to be met.
In universal precaution, I think that was my biggest lesson is not making assumptions just because someone has a college degree.
Yeah.
But if, you should be able to find this online, but if you can't, I will scan it to you so you can have it available for folks if you'd like.
We really would. Thank you.
I'm not seeing any other questions in chat unless I'm missing them, or any other comments.
I'll just take the opportunity quick to look at our action plan for this week. As you all know, this is our 5th week, and next week we definitely have more in store for you in our 6th session. So for this week, we do have an opportunity to just talk a little bit about the option for an action plan. And it's to choose one of the educational resources provided today. And as I mentioned, we will get those right out to you as far as the direct links. But using that resource, practice the teach back method. I just, as exampled, I just wanted to be sure I explained that correctly. Can you tell me you heard me say about, which is a type of use of teach back. But, really definitely taking a look at all the resources offered today and seeing what may be helpful to your health system and your specific work in this area. See what may be helpful, try something you haven't tried, or maybe try something in a new way that you already know about, because now that Karen has given her examples and understanding, sharing it with you, you may try something a little differently with a already known resource. We will entertain additional questions. We don't have to end questions, but if you do have questions about the action plan or anything else, again, we've covered so much. And here we are at week 5. It may be something too that you have a question about in previous weeks that feel free to ask the question. Most likely, we have Janelle on the call today. We have Dr. Campbell on the call today. And then, we can see what we can do about your question if there's something that wasn't mentioned today. And again, feel free to put it in the chat, such as Maria without her mic.
Can I just say thank you to everybody for everything that you do? Thank you for asking me to do this today. And, I think the first time you get feedback about the information that you provided to a patient, or when you do teach back and realize, wow, someone didn't understand that, and now they have a chance at doing it right. It's just makes all of this worth it. I know everybody's busy, so I just want to say thanks to everybody.
And we just had from Maria. She said she would love to have more conversation about the PCP partners and how we can get more education started in a very early stage of CKD.
Yeah, I think that is that's going to be an effort that different programs make. I know here we have I think they do it once a year, and with COVID, I'm not sure, but once a year they do a large conference for PCPs on exactly that and encouraging early referral. So, so we're doing it via conference in terms of trying to educate. I think, the National Kidney Foundation is trying to put efforts at making sure there's early referral and changing something that seems simple, like changing the GFR so that it's GFR and not black and non-black, so that referrals are happening in a timely way for everybody, or at least encouraging the odds of that. So I think that's a really big systemic issue that I don't have the answer to other than how we're addressing it here locally. And, it's through the volunteerism of our physicians and dietitians and others to try to educate PCPs.
All right, any other discussion or questions? If not,
Mute. Oh, I was just going to say, Mary, I was putting it in chat quick, but I'll say it then too.
Mhm.
I just wanted to encourage her, if there's something that you would like to know more about related to CKD or discuss more during our session next week, our session 6, please feel free to
Oh, Jerry, you went on mute.
word. Evidently, my computer didn't think it was important. I was going to say you can email me at jhenniker@stratushealth.org. We just want to make sure. I mean, we have a pretty full agenda, but if there's things specifically that we talked about one week that you'd like to know more about, or just even discuss with the other participants, just let us know, and we'll make sure that we that's included. So again, it's jhenniker@stratushealth.org. I think we lost the slide that we actually had our contact info on. So we'll just put it in chat.
Yeah. Well, thank you, Karen. This has been a great day. Again, another great session, and really wonderful to see our participants, and also the things that you share with us has been great. So we look forward to seeing everyone next week, and you have a great rest of your week. Thanks for attending.